Hi all, my name is Tovy Kamine. I am a trauma, acute care, and critical. Over the last couple of decades, there have been many discussions about prophylactic surgery for long-duration spaceflight. This has understandably been focused mostly on appendectomy and cholecystectomy due to the risk of disease impacting the mission. However, recently there has been interest from the Russian Institute in Biomedical Problems in possibly doing prophylactic splenectomy to mitigate the risk of radiation damage to the spleen, causing cancer or other disease after an astronaut, cosmonaut, or taikonaut has returned to Earth. Over the next 10 minutes or so, we will briefly discuss the anatomy and physiology of the spleen, and we will go over the risks to the spleen from long-duration spaceflight. Next, we'll touch on the risks of splenectomy, both immediate and delayed. And finally, we will summarize the risks and benefits of prophylactic splenectomy and talk about some recommendations. The spleen is an organ in the left upper quadrant of the abdomen, about the size of a clenched fist. The average spleen weighs about 170 grams and is tucked up behind the stomach, lateral to the pancreas, superior to the colon, and just underneath the diaphragm. The spleen has a single artery entering it, which comes off of the celiac axis, and a single vein exiting it, which drains into the portal vein. The spleen provides two major functions, an immune function and a filtering function. The white pulp is the immune tissue. This tissue has B cells and T cells in it that are involved in the adaptive immune response, especially against encapsulated organisms like Haemophilus influenza, Neisseria species, and pneumococcus. The red pulp serves as a filter for the blood that goes through it, filtering out old and damaged red blood cells. An important note here about splenic physiology. The spleen has a very large number of white blood cells, including lymphocytes in the white pulp and macrophages and monocytes in the red pulp. This large concentration of lymphocytes in the spleen plays a role in the development of hematopoietic malignancies like lymphoma in patients who have radiation to the spleen. To sum up this very basic introduction to splenic anatomy and physiology, the spleen provides a few very important functions to the human body, which will impact the concerns we will discuss below. The spleen has roles in filtration and storage of red blood cells and platelets, helps maintain iron homeostasis with the liver, and is critically important for infection prevention. Moving on now to the second section of this talk, I'll touch on the key risks to the spleen from long-duration spaceflight. These risks are trauma and radiation. This picture here on the left of the screen is actually a spleen that has been taken out for a grade 5 splenic lac. I'll start with splenic trauma because I believe it is an under-recognized risk from long-duration spaceflight. The spleen is the most injured organ in blunt trauma, despite its small size. It is also commonly injured in penetrating trauma. Most of these injuries are from rapid decelerations, as in motor vehicle crashes. Because the spleen sits in the retroperitoneum, but is intimately attached to peritoneal structures, rapid deceleration can cause shearing injuries to the spleen, as the peritoneal structures continue moving, but the retroperitoneal structures stop. Splenic injuries are graded on a scale from 1 to 5, 1 being a small laceration or hematoma, and 5 being a complete disruption of the spleen. Grade 1 and 2 injuries are considered low grade and often heal without intervention. Grade 3 injuries are intermediate and may require intervention, whereas grade 4 and 5 injuries are high grade and almost always require intervention. In the modern trauma system in the United States, this means that pretty much all grade 5 injuries end up requiring splenectomy, and most grade 3 and 4 injuries can be managed with angioembolization, though some do end up requiring splenectomy as well. Approximately 30% of all splenic injuries in the United States are high grade. High-grade splenic injuries also have a very high mortality rate, even with the standard of care in the United States. Approximately 1/3 of high-grade splenic injuries will die even with angioembolization or splenectomy. The mortality of these patients without procedural intervention is close to 100%. Given these concerns, it is highly likely that an astronaut who suffers a severe splenic injury will die, especially as there is unlikely to be a trained trauma surgeon and the large volume of resuscitation necessary on a spacecraft to care for these patients. Fortunately, the risk of splenic injury is probably not very high in microgravity, though the risk is much likely higher on a lunar or Martian mission with the risk of uncontrolled spacecraft landing or a collision involving a lunar or Martian rover. Moving on to the radiation risk to the spleen, I have a couple of slides here with a brief primer on radiation units and measurement. As with everything else, there are both imperial and SI units, but I will use SI units in the talk, and that's what you'll hear me reference below. Radiation units are broken down into radioactivity. This is the amount of radiation released by material, measured in becquerel. Exposure. This is the amount of radiation traveling through the air, which is measured in coulomb per kilogram. Absorbed dose. This is the amount of radiation absorbed by an object or person, and is measured in gray. And finally, dose equivalent or effective dose, which is measured in sievert. The effective dose is what really matters here to determine the effect of radiation on tissues like the spleen. Fortunately for radiation oncologists, for practical purposes in the radiation literature on Earth, 1 gray is equal to 1 sievert. Unfortunately, this is not the case in interplanetary space because many cosmic radiation sources are proton, neutron, or alpha radiation, which have a much higher effective dose than the many gamma and X radiation used in the medical literature for radiation oncology. Because of this discrepancy, for the remainder of this talk, I'm going to use only sieverts and millisieverts and talk about effective dose. This is the chart here of the effective radiation doses in millisieverts on humans. At the very bottom here, we have the 0.1 microsieverts one gets from the potassium, radioactive potassium in eating a banana, up through the doses from medical X-rays and cosmic radiation on an airplane, towards the top, where 1 sievert, or 1,000 millisieverts, in a single exposure is enough to cause radiation sickness, and 7 to 10 sieverts in a single exposure is enough to kill a human being. So let's talk about interplanetary radiation risk sources. The 1-year dose limit for astronauts is 5 sieverts. You might recognize from the previous slide that a single dose of 5 sieverts would be more than enough to cause severe radiation sickness. But over the course of the year, this is not necessarily the case. A solar particle event during interplanetary spaceflight could expose astronauts in a spacecraft to up to 5 sieverts of radiation in a single event, while an astronaut on EVA during an SPE would likely receive a very lethal dose of 14 sieverts. Barring solar particle events, however, the expected radiation exposure to an astronaut on a 21-month round trip to Mars from solar and cosmic radiation is approximately 1 sievert. This is enough to cause mild radiation sickness if received all at once, but over the entire trip, not nearly so. Fortunately for us, the first slide gave us information on the risk of a single dose radiation exposure, which comes from nuclear weapons testing and from Chernobyl. But there's also very good data for us on the risk of medium-term to long-term radiation exposure to the spleen, rather than those one-time high doses that cause radiation sickness and death. Most of this literature comes from the radiation oncology literature, which is prodigious about the effects of radiation to the spleen, mostly from gastric or renal cancers. These are the total radiation doses from a 3 to 6 month cycle of radiation therapy, so the individual doses for each session are much lower. By 10 sieverts cumulative dose over 3 to 6 months, a patient can expect splenic volume and functional loss. This includes pancytopenia, and in particular neutropenia and leukopenia, as well as thrombocytopenia and anemia. These collectively significantly increase the risk of infection. It takes a much higher dose, however, to increase the risk of hematopoietic malignancy. A 40 sievert cumulative dose over the course of 6 months to a year increases the risk of hematopoietic malignancy by 3 to 5 times. In comparison to the risks of leaving the spleen in prior to long-duration spaceflight, the risks of splenectomy are myriad and include both immediate and delayed risks. The immediate risks, which covers the perioperative period and the first month or two after splenectomy, include intraoperative complications such as hemorrhage and gastric or pancreatic injury. These risks are pretty rare, only occurring a few % of the time at most with splenectomy. In addition, however, the thrombosis risk after splenectomy is increased, particularly DVT-PE and portal venous thrombosis, which occurs in 6 to 10% of patients who have splenectomy. The delayed risks of splenectomy include overwhelming post-splenectomy infection or OPSI, with about a 5% lifetime risk, and other gastrointestinal tract malignancies, which increase with a relative risk of 1.5 to 2.5 times after splenectomy because of the decrease in immune function. Overwhelming post-splenectomy infection, or OPSI, is the most feared risk after splenectomy. It is caused by the encapsulated organisms, such as pneumococcus, H. flu, and Neisseria species, and is a result of a lack of immune function of the spleen. Historically, this used to be a much greater concern, but with the advent of vaccines for these encapsulated organisms, the risk of OPSI is about 0.3% per year, or 5% lifetime for a pediatric splenectomy. OPSI causes rapid mortality from septic shock within 24 to 48 hours of onset, and is treated with antibiotics, but unfortunately has a very high mortality rate. Since the treatment is not terribly effective, prevention is best for OPSI, which is effected by giving all splenectomy patients the quote-unquote post-splenectomy vaccines for these organisms, either 2 weeks after splenectomy if it's done emergently, or prior to splenectomy if it's done electively. These vaccines are extremely safe with minimal side effects. To put some numbers to what we've discussed, the immediate risks of splenectomy are 1 to 2% for an intraoperative complication, 6 to 10% for a thromboembolic complication, and about a 5% lifetime risk of OPSI. This gives us a total risk of 12 to 15% for a potentially lethal complication from splenectomy. In contrast, the risks of trauma to the spleen on long-duration spaceflight are difficult to quantify, but are likely not very large. and the risk of hematologic malignancy from radiation on long-duration spaceflights are probably less than the risks of gastrointestinal tract malignancy from splenectomy. The risk of significant radiation from an SPE include many systemic radiation issues, such as radiation sickness or death, which splenectomy will not affect. The most likely result of radiation on the order of 1 to 2 sieverts from the Mars mission is hyposplenism and volume and functional loss. Even assuming generously that this radiation causes a 20 to 30% reduction in splenic volume and function, this is still better than the 100% reduction in splenic volume and function from a prophylactic splenectomy. We can thus say with some confidence that the risk of prophylactic splenectomy greatly outweighed the benefits. Finally, to get to some recommendations, prophylactic splenectomy is not indicated prior to long-duration spaceflight. However, the risks of hyposplenism from radiation exposure in long-duration spaceflight are real and may best be mitigated by the administration of the quote-unquote post-splenectomy vaccines prior to flight. Here are some references for the talk, and thank you very much. Please email me if you have any questions or comments. My email address is tovy.kamine@baystatehealth.org. Thank you so much.